Good afternoon, everyone. I welcome you all in today's masterclass. If you all know, this masterclass we are organizing for now more than 6.5 years. This is seventh year is going on. We have discussed many different kind of problems which happens in the children. So today's masterclass is allotted to plastic surgeons who are practicing mainly pediatric plastic surgery. Of that, the cleft is one of the commonest problem, and today we will be discussing about the cleft lip, cleft palate, primary problems, secondary problems, etc. We have three speakers with us: Dr. Mahinoor Desai, Dr. Nitin Mokal. Nitin Mokal is the head and senior professor, and Dr. Prasanna. So they will be telling us about all this kind of problem. As you know, at SRCC Children's Hospital, we treat almost everything in children, which includes uh, neurosurgery, cardiac surgery, bone marrow transplant, solid organ transplant, general pediatric surgery, laparoscopy, thoracoscopic surgery, etc. So under one roof, we can take care of everything for children, including some of the antenatally detected anomalies have been managed. I'm Dr. Rasik Shah, pediatric surgeon, and we have been organizing this masterclass for now so long. And I thank you all for attending this masterclass every monthly, which is usually on third Wednesday of every month. Thank you. With this, I'll invite Dr. Mahinoor Desai. She will be telling us about cleft lid, overview of cleft lip and cleft palate. So she will be telling us about that. Uh, so Mahinoor, please take over. Hello.
Hi. So I'm Dr. Mahinoor Desai. I'm a pediatric plastic surgeon at SRCC Children's Hospital. And today's topic is titled Roadmap to Cleft Care. So we'll take you on a journey that our cleft children go through from birth to full growth so that we can be familiar with what intervention needs to be done at what time so that they have a smooth progression to the end of treatment. So our first lecture is going to be by Dr. Prasanna. He is going to give an overview. Then I will be talking about the correction of cleft lip, palate, palatal fistula, and alveolar bone grafting. And after that, Dr. Nitin Mokal will be talking about secondary deformities and their correction. And then after the break for Q&A, we'll be talking about acute airway emergencies and cleft palate. That is Pierre sequence. Dr. Prasanna will be presenting on them. And then after that, a short presentation on rare craniofacial clefts, again by me. So this is a broad overview that of the treatment, and at each stage there are some things that need to be done for the child and the specialists that are involved. So we'll be going over this repeatedly in our next three presentations. So you have an idea at what stage what needs to be done so you can make the appropriate referral. And all children with cleft lip and palate will require multidisciplinary treatment, not just surgery, but all the supportive specialties like speech, dental, genetics. And as the pediatrician, you are going to be the cornerstone for coordinating all these things. And sometimes a lot of psychosocial counseling is also required because some people feel like giving up or they don't know what is the right thing to be done and they are stuck. So that is the point where you step in because they are your patients, they will listen to you. And this is how our normal roadmap should progress from beginning to end. Every stage there is a definite intervention to be done. And if it progresses smoothly from beginning to end, you have a well rehabilitated patient with very little stigma or deformity. If it does not go according to plan and you deviate off the roadmap, then you can end up with secondary deformities, which will require extra treatment. So you as a pediatrician are a vital member of our team also, and you have to keep the continuity and follow up for these children. With that, we'll be going to our first lecture by Dr. Prasanna Somvanshi.
Yeah. Mm.
Good afternoon, everyone. I'm Dr. Prasanna Somvanshi. I'm a consultant plastic surgeon at SRCC Children's Hospital. I'll be talking on the overview of how cleft lip and cleft palate patients are to be managed, what all difficulties do they face, and how the treatment protocol is to be followed. We'll be briefly going through the topic under the following headings. We'll start with the embryology of the face. Then we'll correlate it with the presentations that we see in the cleft child. Then the factors which lead to cleft lip and clefting in children's. The antenatal counseling, what all things can be done for prevention, and the protocols for surgical management. So going through the embryology of the face, so the development of the face usually occurs in the initial part of the gestation, around 3 to 8 weeks. So at around 3 weeks of gestation, around the cephalic end, the cephalic end basically develops into the face. The face develops primarily by 5 processes. There is the frontonasal process, the 2 maxillary processes on either side, and the mandibular processes. And in between all these processes, there is a pit, which is initially covered by a membrane called as the oral membrane, which gradually degenerates, which leads to the formation of the oral pit. And here you can see on either side of the frontonasal prominences, there are 2 depressions, which are the nasal placodes. These depressions eventually develop into the nasal pits, and there are two processes which form. There is the median nasal process and the lateral nasal process on either sides of the nasal placoid. So as the development progresses, gradually the processes basically fuse in the midline. The two median nasal processes fuse, which forms the columellar region and the filtral column region. The maxillary processes and the lateral nasal process, all these things fuse to give us a complete upper lip, and the mandibular processes fuse in the in the lower part to give us the lower lip region. This is just a demo, the same thing. The maxillary and the upper lip region comes from the maxillary processes. The lower lip and the lower lip and the chin region comes from the mandibular processes. So correlating this embryology to what happens when we have a child with a cleft lip. So in a unilateral incomplete cleft lip, there is failure of fusion of the median nasal process and the maxillary processes. So here you can see the median nasal process and the maxillary process are not fused, and this defect does not go into the nasal floor. So coming to the unilateral complete cleft lip and the primary palate, again, there is failure of fusion of the median nasal process and the lateral nasal process and the maxillary processes. So there is a complete through and through defect which continues up to the posterior going into up to the primary palate. Same thing when there is bilateral incomplete cleft lip, there is failure of fusion of the bilateral maxillary processes with the median nasal processes. So again, in incomplete lips, the defect does not extend into the nasal floor. In bilateral complete cleft lip and primary palate, there is failure of fusion of the median and lateral nasal processes and the maxillary process bilaterally. So we have a complete defect which is going into the primary palate, which involves the lip, the alveolus, and the primary palate. There are a few rare clefts like the oronasoocular cleft, which is called as Tessier's cleft 4. Here there is failure of fusion of the lateral nasal process with the maxillary and the medial nasal process. Here, if you can see, the cleft is going through the nasal floor and extending up to the medial orbital wall. Here you can see there is a bilateral cleft 4. The previous picture was a unilateral cleft, Tessier cleft 4. Here there is a bilateral Tessier cleft 4. It's extending from the lip, going through the lateral ala and up to the medial orbital floor or medial canthal region. Then there is the angular cleft 7. Basically, there is a failure of fusion between the maxillary and the mandibular process on either side. This is also called as macrostomia, which is easily surgically corrected. These are some of the rarer clefts. This is cleft 4, 1, and 12 with orbital hypotelarism and encephalocele. And the midline cleft. Here, there is failure of fusion between the medial nasal processes on both the sides. So basically, orofacial clefts, the craniofacial clefts, there is genetic etiologies to it. It can be associated with certain autosomal recessive syndromes. Some can be autosomal dominant. We'll be looking into these syndromes later on. The craniofacial clefting can also occur because of exposure to certain teratogens. Multiple growth factors are also involved. The primary growth factors which are of importance for us for clefts are the sonic hedgehog and the bone morphogenetic proteins. Again, if the insult happens before 3 weeks, we get more of the craniocerebral dysplasias, which like the anencephaly. And if the insult is happening between 3 to 5 weeks, we get more of cerebrocraniofacial dysplasias, facial defects like holoprosencephaly. Now, coming to the causes of cleft lip and palate, there are multiple factors like the environmental factors, the maternal factors, and the intrauterine factors. In environmental factors, we have the lifestyle and environmental risk factors where there is maternal exposure to tobacco. This increases the risk of craniofacial clefts by up to 20%. Then exposure to alcohol during the initial 3 to 8 weeks of gestation may lead to fetal alcohol syndrome, where the isolated cleft palate is also a component. Poor nutrition, multivitamin deficiencies during the early part of the pregnancy is also related to development of cleft child. Viral infections and certain medical drugs which are considered to be teratogenic in the initial part, like the anticonvulsant drugs like phenytoin and sodium valproate. So viral infections are associated with the activation of interferon regulatory transcription factors, and IRF6 have been associated with increased risk of clefts. So that's how viral infections during early pregnancy can lead to development of a cleft child. Also, fetal molding, when there is oligohydramnios or decreased amniotic fluid levels during the early part of the gestation, the head basically it remains flexed and against the chest. So there is improper development of the lower part of the face. So eventually the tongue cannot move ahead and it might lead to isolated cleft palates. Also, cleft lip with or without cleft palate is a feature of more than 200 specific genetic syndromes, and isolated cleft palate is associated as a condition with more than 400 such syndromic disorders. Coming to the genetic part, if the first child is found, if the first child has an isolated has a cleft lip or a cleft palate, the chances of the second sibling having a cleft is around 2 to 3%. If the first child has unilateral cleft lip and palate, the chances of the second child having is like 4%. So genetic counseling after having a cleft child is very important, which these risks have to be explained to the parents that the subsequent child may also develop clefts. Multivitamin supplements multivitamin supplements before conception as well as in the initial part of the pregnancy have also led to a 25% decrease of orofacial clefts. And zinc is also considered an important component during the fetal development. There was a study conducted in Philippines, which was an endemic zone for zinc deficiency, and in females and in mothers who had zinc supplements during the initial part of the pregnancy, there the chances of orofacial clefts was found to be reduced. So basically, this was a dose-dependent relationship between zinc and development of orofacial clefts. So there are certain syndromes associated like the Vanderwood syndrome, the Mokal syndrome, Robert syndrome, also the Pierre syndrome. So these are the syndromic associations of clefts. So why the cleft problem is of so much importance? Because if you consider only India, there are approximately 34,780 plus children which are born with a cleft every year. And the incidence is around 1 in 800 live births, where there are orofacial deficiency, orofacial clefting. So as we have discussed earlier, the facial development occurs between the 3rd to the 8th week, and any insult during this process, during this period, leads to orofacial cleft deformities. So there is no concept of pregnancy planning in India as of now. There is smoking, drinking, alcohol consumption, food habits and lifestyle are very rampant, and vitamin deficiencies also. So that, like, orofacial clefting is a preventable complication. So it needs a proper planning of 3 to 6 months. Need to adopt a healthy lifestyle, healthy food habits, iron, folic acid, and zinc supplements, and both the husband and wife should be mentally and physically fit to undergo the pregnancy, and there should be planned coitus around 10 to 14th day of the cycle. So if there is antenatal detection, so nowadays it is very much possible to detect cleft lip and cleft palate in the antenatal period. So the scans around 20 weeks, the 2D scans, there is a detection rate of up to 93% for cleft lip and palate patients. But again, the scans are operator and technique dependent. The mother's body habitus, the amniotic fluid volume, the fetal position, and the type of cleft, all these factors affect the detection and diagnosis. So as an adjunct to the 2D scans, there is the 3D scans which are available. Again, there is volume restoration and multiplanar imaging, and like we can have a better and clearer view of the cleft lip and cleft palate. Sometimes the clefts can be detected as early as in the first trimester itself. So once if in the antenatal period, if the child is detected to have the cleft lip and cleft palate, so the proper counseling of the parents is much necessary. All the possible outcomes and the realistic information needs to be provided. We need to explain to the parents what they are going to deal with once the child is born, and we also need to explain that cleft lip and cleft palate is a totally treatable problem, and we can have very good outcomes if all the proper protocols are followed, and the child and the parents remain in proper follow-up with the cleft team. So for that, we need to engage the parents properly in the treatment planning. We need to explain the entire surgical protocol to the parents, and we need to provide and proper pre and post surgical support to the parents and the children is also necessary. Also, the parents can be helped to get in touch with organization and support groups so that they can go through this journey easily. Sometimes we don't have a prenatal diagnosis of cleft, and suddenly at the time of the birth, we come to know that the child is having a cleft lip or cleft palate or both. So in such conditions, we need to give proper psychological support to the mother before showing the deformed child to the mother as well as the other family members. Again, the children and the parents and the other relatives need to be explained that the condition is completely treatable and the child can have a very much normal life. All these things are necessary for a smooth functioning of the to develop a proper parent-child relationship also. Again, treating a cleft child, we need a multidisciplinary team, which includes the cleft surgeon, the orthodontist, the pediatrician, the speech therapist. We also sometimes need the ENT surgeon also, psychologist, nutritionist, and social workers. This is a brief overview of the treatment schedule that we follow. So initially up to 3 months, 3 to 6 months is the first surgery. So up to 3 to 6 months, it is the primary aim of the parents should be that the child should get proper nutrition via breastfeeding or top feeds, or however the pediatrician is trying to manage, so that the child is ready for the first surgery by 3 to 6 months. So initially that we follow is the rule of 10 for the first surgery, that the child should have 10 pounds of weight. The hemoglobin should be 10 grams and at 10 weeks of age. After that, we go on to the cleft palate surgery, which happens at around 9 to 12 months. Gradually, at 18 months to 2 years, we start with the speech assessment and speech therapy. As the primary dentition, as the child starts developing primary dentition, we start with the orthodontic treatment. And around 7 to 10 years, we go for the alveolar bone grafting. After that, for at 12 to 13 years of age, again the patient continues with the orthodontic treatment. And by the time he reaches 16 to 18 years, we plan him for the orthognathic surgery if at all it is necessary. So in the initial part of in the initial first 3 months of the child's life, the primary aim of the parents have to be that that the child is receiving adequate nutrition and his weight gain is as per a normal child. For that, we need to encourage breastfeeding. The breastfeeding in a cleft child is very much difficult because when a normal child when you do breastfeeding for a normal child, it is very much easy because the lip seal, the tongue, the palate, and the lateral pharyngeal walls, they form a closed space. So the child can suck onto the mother's breast and there is free flow of the milk. But what happens in the cleft child, formation of the negative suction in the intraoral cavity is difficult because there is a communication between the oropharynx and the nasopharynx. So in such patients, in such cases, we need to teach the mother how to breastfeed the child. So basically, prior to breastfeeding, the mother should be explained to apply hot packs to the breast around 20 minutes before breastfeeding. Gentle massage around of the breast and around the nipple helps in the letdown reflex. This allows for the free flow of the milk into the baby's mouth. Also, applying gradual pressure around the nipple helps for the release of the milk. So it is easier to feed the child. Certain specific positions have been explained because nursing a cleft child in a normal position, in the lying down position, it is difficult because there are chances that the child might aspirate the blood, aspirate the milk into the respiratory tract. So there are certain positions described, which is the modified football hold position or the straddle position. These positions help for the milk to be deposited more on the posterior part of the tongue so that the effect which is negated because of the suckling effect is overcome. There are certain specific feeding bottles also which are available, like the cross-cut nipple. There is the Haberman's feeder. The basic aim behind using these things are that the milk should be deposited on the posterior part of the tongue so that the child can swallow it easily and the chances of regurgitation are less. Also, if breastfeeding is not adequate, then the parent should be explained for the supplementary bottle feeding. The advantages include that it encourages adequate intake, conserves the infant and mother time and energy, and it allows for the normal suckling with the bottle, and it is inexpensive and readily available. We'll just have a short video. This is a video which is freely available on YouTube. This helps to understand how breastfeeding in cleft child can be managed.
Some children are born with a cut lip or a hole in the roof of the mouth. This is a very common birth defect. But in the hands of a good surgeon, it can be fully corrected, and that too totally free. The hole in the roof of the mouth may not be visible from outside, but must be closed. If not done at the right age, this will prevent the child from speaking properly when he grows up. There may also be other problems such as milk and food coming out of the nose, as well as repeated bouts of cough and cold and other chest and ear infections, making the child fall sick frequently. The only way to close the hole in the roof of the mouth is through surgery, and to make the child fit and strong for that surgery, they need to be fed adequately. Mother's milk is like nectar for the child. There is no food better for the child than mother's milk. But because of the hole in the roof of their mouths, many such children are not able to take in milk properly. Instead, they suck in a lot of air, and even though they feel full, they haven't received adequate milk. Sometimes it comes out through the nose or could even go into their lungs. Because of the extra effort, many children tire easily and fall asleep, and the mother feels the child has taken the full feed and gone to sleep. In this video, we will show mothers how to feed such children. The best way is to feed the child directly from the breast. For this, the mother needs to hold the child upright so that the milk goes into the stomach instead of coming out through the nose or going to the lungs. The nipple should be directed towards the side of the mouth that does not have a cut. Since the baby is not able to suck with enough force, the mother should simultaneously squeeze her breast to increase the flow of milk. But do this gently. Sometimes these children may not be able to swallow the milk if it comes too fast, and some of it could come out of their mouth. If this happens, stop and slow down. With a little practice, the mother and child can set a flow rate that the child can handle, and both will soon adjust to one another. These children also suck in a lot of air as they are taking in the milk and need to be burped more often. For that, put the baby on your shoulder and gently rub his back down up until you hear a burping sound. This needs to be done a few times during feeding and at the end of feeding. If for any reason feeding from the breast does not work, the mother can also expel her milk from the breast into a container and feed with a spoon or through a bottle. Special feeding containers are available at some places, and these can be used. Or you can enlarge the hole in the teat of a feeding bottle to increase the flow of milk. The mother must make sure the container, spoon, and bottle are clean and sterilized. For this, they must be kept in boiling water for at least 10 minutes. Feeding through unclean containers, spoons, and bottles can lead to infections and fever. If the mother is simply unable to feed her own milk for any reason, the next best thing is to give cow's milk or formula milk. This is clearly not the best, but if mother's milk is just not available, the child can be fed with these. It is very important that the cow's milk is pre-boiled and cooled, and then fed with a spoon or through a bottle. It should never be diluted. If using formula milk from a tin, make sure the water used is absolutely clean and preferably boiled. After boiling the water, let it cool before mixing with the powdered milk. Make sure the proportion of powdered milk in water is exactly as recommended. Feeding dilute milk will not give the child the nutrition needed to become fit for surgery. It is worth repeating. Please make sure all containers, spoons, and bottles you use are clean and sterilized. If the child is just unable to take any form of milk, he should be started on soft food and cereals as early as possible. But for this, you must consult a doctor. The smile trees.
So this was a brief description of how feeding in a cleft child can be done. Now we'll be going on to the next we'll be going on to the next topic, which covers the surgical management of the child with cleft lip and cleft palate.
Hi. Thank you for being patient with us. We are experiencing some technical difficulties today. So my topic is the correction of cleft lip and palate as primary surgery. So I showed you this timetable earlier. So the surgical repair of the lip at 3 to 6 months, surgical repair of the palate at 8 to 12 months, and then we assess the child regularly for the speech, and if any correction of speech is required, or if there's a palatal fistula, we will do it in the age group of 1 to 5 years. And at around 7 years, we start the orthodontic treatment to prepare the child for alveolar bone grafting, which is typically done between 8 and 11 years of age. The remaining part of the surgical correction will be covered by Dr. Nitin Mokal in the next one. So the goals of primary surgery are to restore the normal anatomy of the child, because as you know, in a cleft, there is a gap in the lip or a gap in the palate. In palatal repair, additionally, you have to reconstruct the muscle sling. That is the main thing that is responsible for good development of speech function. And in the alveolar bone grafting, you have to fill in the bone gap so that the teeth will erupt naturally across the cleft. So, what we require from our pediatricians are that they should be aware of the age groups at which the different surgeries are done. And when the patient is admitted, the pre-operative checkup, we always refer to our in-house pediatrician. And some NBN guidelines are there, as you are aware, like 6 hours prior, milk and solids are allowed, and 4 hours and 2 hours prior, only clear liquids are allowed before the surgery. This is all to ensure that the child does not become hypoglycemic and there is good recovery from anesthesia. If a lot of times there are comorbidities, then of course the pediatrician or the pediatric cardiologist will be involved. Our anesthesia providers also do a pre-evaluation, and post-op monitoring for pain and bleeding is obviously a must. So these are some of the things that when you are seeing the child over the course of the first few months, you should keep in mind. All vaccinations should be done as per schedule. And if you feel that any other problem is cropping up, then you should refer to the appropriate specialist. So So this is a good outline for a pediatrician to keep in mind. And for us, the most important thing is the weight gain and adequate hemoglobin, so we can proceed with surgery in a timely fashion. So this is the normal anatomy of the lip. And when there is a cleft lip, there is disruption of this anatomy. So the goals of our surgery are to restore these normal landmarks, especially white roll and Cupid's bow. So as you can see in a cleft lip, there is abnormal attachment of the orbicularis oris muscle. So all our surgical techniques are aimed at dividing the abnormal attachments and restoring the normal anatomical sling of the orbicularis oris. So this, as you can see, this is an incomplete lip where there is continuity of the nostril floor. And this is a bilateral lip, complete cleft lip and palate. So depending on the degree of the deformity, we will do the appropriate surgical technique. Now just a note about nasoalveolar molding. This is best done within the first 3 months of life because the maternal estrogens make the cartilage more elastic and amenable to molding. The greatest advantage is, of course, they bring the nostrils up, they bring the lateral segments together, so the surgical repair becomes easier. The disadvantage is it puts an additional burden in terms of cost and the visits to the prosthodontist or orthodontist who is doing the remodeling. So that might not always be possible for all patients. And studies have shown that the results that you get from the pre-surgical molding do not last in the late post-surgical period, that is at 1 year of age. So, like Dr. Prasanna introduced, lip repair is done anytime between 4 to 6 months of age. The hemoglobin has to be more than 10 gram percent, weight should be more than 5 kg. The child should be fit for anesthesia. So, historically, many techniques have been described for the repair of the cleft lip. And all of them involve some kind of geometrical construct like a triangle or a quadrangle. So our group uses a combination of different techniques, but whatever technique that we are using, the basic steps remain the same. So if there is a baby between 4 to 6 months of age where we are doing only the lip repair, then we close the anterior palate also using the Vomer flap. And we realign the orbicularis oris muscle to get a muscle sling. And we do layer closure of the mucosa and the skin, and we adjust the vermilion thickness. Now, for intra and post-operative analgesia, we also give an infraorbital nerve block. And of course, additional post-operative supplementation with suppository. And in our center in SRCC, we use the anesthetists use the Dexmed drip for immediate post-op analgesia, which works very well. So this is what I mentioned. The first step is to repair the anterior palate using the Vomer. So if you can see, this is the vomerine bone. The mucosal flap has been lifted off it and tucked under this palatal flap. So later on, this will heal completely and we will only have to repair the secondary palate. So I've chosen this case of a 1-year-old child because, it is easier to demonstrate in a bigger child the steps of the lip repair. So when you're doing in a 1-year-old child, we do a simultaneous repair of the palate and the lip. So there is no need for Homer flap as such because we are actually repairing the entire palate. So this is the initial part. We do the palatal repair first. This is using two long flaps on the palatal side. And after the palate is repaired, then we proceed for the lip repair. So these are our markings for the lip repair. We use the Millard's technique, which is a rotation advancement technique, but we have several modifications over the original Millard's, one of which is this Molars modification, where we take a small triangular extension into the columella. So when this flap rotates downwards, then this columella defect will close and you will not have a zigzag across the base of the columella. And an additional modification is this vermilion adjustment using Dr. Rajesh Pawar's step ladder technique. So like I said, we use philosophies of the earlier surgeons, but we have evolved our own technique. So the first stage after raising this columella flap, which is called the C flap over here, is to dissect the muscle from the skin and the mucosa side. And this is called the medial mucosal flap, which will go across and act as a bridge across the alveolus. And next step after that is we do a close dissection of the nasal alar cartilages, entering this from the medial side incision at the base of the columella. So this technique is the closed rhinoplasty technique. And some people do an open rhinoplasty also, but we prefer not to cause additional fibrosis. So we are basically just dissecting the domes of the alar cartilage on both sides and then the entire remaining length of the alar cartilage on the cleft side. So later on, we will suspend these mobilized cartilages so that we get a better shape of the nostril. So after doing that, then we do the dissection on the lateral side of the lip. We disconnect it from its attachment to the alveolus. And you can see now this side, the medial lip was dissected, so it has come to its normal horizontal level. This side, the lateral lip has been dissected and it has come to its normal horizontal level. So this is a video showing the dissection of the lateral lip element, that is the cleft side. The incisions are taken as marked, and we discard very little mucosal tissue. We keep as much as possible to use. So once the incision is taken, then similarly we dissect the muscle again from the skin side and from the mucosal side. So this is separation of the muscle from the mucosal side. And this is separation of the muscle from the skin side. So this way you're freeing up the alar base also on that side, because some of the abnormal attachments of the orbicularis oris go into the alar base also. So you can correctly reposition the alar base later at a higher level. So once all the dissection is complete, we take these temporary alar molding sutures with 4,0-ethylon, and you can see how the nostril gets lifted to a nice normal dome after taking these sutures. So the next step is we have to close now the nostril floor. And this is what we use this is a turbinate flap, which is also going to contribute to the nostril floor closure. So this was our earlier repaired anterior palate, and this will sit nicely in this gap between the two halves of the alveolus. This you can see is the earlier median mucosal flap, which was raised. It goes across and sits on the opposite side alveolus. So we get a closure of the oral side. This is the dissected alar base. And now we are going to start reconstructing the skin side. So this is an important suture that we use to decrease the tension at the top of the repair. It's called the alar cinch, and it goes from this side alar to the opposite alar, and is taken with 4,0-ethylon. I'll just show you how we take the suture. So we take a good bite of the subcutaneous and whatever fibrofatty tissue is there at the base of the alar. And we go across the septum to the opposite side alar in the subcutaneous plane. Additionally, you can take a nostril floor suture across both the nostril floors after the suture is taken, which will also help decrease the tension at the top of the repair. So you can see now the nostril base has got quite narrowed. Earlier it was big and wide, and now you can see how nice and narrow it has become. And this is the muscle has been repaired already. I'll show you a video if possible of the muscle repair also. And this is the mucosal layer that has been sutured. We do a subdermal closure with 50 andite PDS, which again helps give you a good aesthetic result. So this is the dermal closure with 40 PDS. Muscle repair is done with 40 Micron. And this you can see now, we had raised the columella flap. So it is sitting at now the base and reforming the columella pillar. Sometimes earlier people used to use it to line the nostril floor also, but in this molars modification, it is just used to lengthen this side hemicolumella. So we use 60 rapid vicryl for closure of the skin, which gives you a good aesthetic result because it's a fine suture. Plus, you are saved the trouble of removing the suture. So it is better for the child and the parents and the surgeon, of course. So this is the alar transfixion sutures. So we had dissected the alar cartilages and the alar base. So we take these sutures with PDS to hold the dissected alar in an elevated position, as well as to close any dead space between the two flaps. Again, this was not described originally by Millard. This has been described by Nudorf. And Dr. Mokal had trained in Taiwan with Dr. Nudorf, and he taught all his students this method. So you can see what we started it and how we have ended up with. Even with a wide defect, we can get a good result. This is the worm's eye view, which is equally important. You can see how with all the alar cinch, the nostril floor closure, and the muscle dissection, this has become this. This is a later post-operative result at around 1 week. These are some of the late post-operative results. Again, with a wide cleft, you might not get such an aesthetic closure, but this is still an acceptable result. This is the same patient with a worm's eye view. This is another patient with a complete cleft lip, worm's eye view. Again, another wide defect with a good result. Another wide defect with a good result. So the nasal slump of the alar cartilage is usually persistent and will require later correction with a rhinoplasty. Same way for the bilateral lip, more or less the principles are the same, the skin incisions, the muscle dissection. In bilaterals, it's just that this projecting premaxilla has to be dealt with. Sometimes you might need a vomerine setback, but most times when you join both sides muscle over the premaxilla, then it remodels over time and you don't need anything more. So these are the results of the bilaterals. So even with wide bilaterals, you can still get a good aesthetic result. So coming to palate repair. So like Dr. Prasanna mentioned earlier, it is done between 8 to 12 months of age. So there was a controversy earlier that if you do too early palate repair, then it hampers maxillary growth. But 8 to 12 months is the correct age if you want good speech function, because the speech starts developing at that time, babbling starts. So if you restore the muscles to their normal anatomical position, then speech will develop normally. This is the anatomy of the normal palate, the hard palate, and the soft palate. And you can see in the cleft palate, the muscles are abnormally attached to the edges of the cleft and to the posterior palatine margin. You can see over here. Otherwise, they would normally go across and form a sling. So in the normal, they would form a sling like this, and in the abnormal, they attach to the. This is the palatopharyngeus, and this is the levator. So you can see in a complete cleft palate the degree of deformity, and these are our two major arteries, the greater palatine arteries. So while raising the flaps, you have to preserve these two arteries to preserve the vascularity of the flaps, otherwise they will necrose. And this you can see in a secondary palate, the anterior palate ahead of the incisive foramen is intact, and the posterior parietal cleft is there. Again, you can appreciate how the muscles are abnormally attached. So, depending on the degree of deformity of the palate, you will design your mucosal incisions accordingly. And keep in mind, they are always based on the greater palatine artery. So, this is a repaired palate where you see we have restored the horizontal sling. It was abnormally attached earlier, and now we have restored the normal horizontal sling. It's called the levator sling. And when you do a proper repair, then the palate automatically lengthens too. We have modified our incisions. We used to take them earlier over here between the alveolus and the palate. But we have modified them to something called the alveolar extension palatoplasty, which gives us this extra tissue as well as it is based on the anatomical watershed zone of the blood supply. So this was introduced by Dr. Michael Carstens from Australia. So this you can see now the gap is much less because we can reattach the gingival margin to the gingival margin. Sometimes when the cleft is very wide or there is a secondary correction, then we take additional tissue from the cheek. This is known as the buccal myomucosal flap. It was described by an Indian surgeon, Dr. Mukherjee, and it has been popularized for primary cleft palate repair by Dr. Robert Mann, who's an American plastic surgeon. So you can either use both sides as in the previous case, or you can use just for one side. And you can see later on it heals very nicely. The pedicle is behind the retromolar region. It does not really get in the way or require division most times. Now, post-operative for palate especially, bleeding is always a major consideration. So we always cross-match and keep blood for all palate patients. The other is the nasopharyngeal obstruction because we have closed the palate and lengthened it. So there is some degree of obstruction. So in our patients, we keep a nasopharyngeal airway. We put it under vision at the end of our surgery. So there is no problem with that. It'll interfere with our sutures or anything like that. We see that it goes beyond the uvula point. And then we attach it to the bag after the patient is extubated and see that the movements of the bag are there. And you can check the EtCO2 reading on the monitor. The other late complications of palatal repair are breakdown, fistula, velopharyngeal incompetence. And for long-term results, you might sometimes get maxillary growth retardation or an unfavorable scar. So from the pediatrician point of view, of course, we need a basic monitoring for the in-house pediatrician, whoever the pediatric residents are there. Inform us if there is any bleeding and inform us if there is any respiratory distress. Usually in our setup, the patient is monitored for half to 1 hour in the OR and then transferred to the ward. Palatal patients don't need to be transferred to ICU as long as you have trained pediatricians and pediatric staff who are aware of what is required in the post-op management. And we start feeding 2 to 3 hours after surgery. with clear liquids, and bottle feeding with nipples on the bottle is absolutely a no-no. So either with a spoon or directly from the cup, depending on the age of the child. You have to keep a watch that the oral intake is adequate. If it is not, then IV supplementation is required. And of course, you have to watch for any other signs like fever or, bleeding. Now, over a period of time, all these children will require an ENT checkup because otitis media is a common co-association with cleft lip and palate children because of the abnormal attachments of the palatine muscles. Then all children will eventually require dental care and orthodontia. Speech monitoring is important. So if the child is following up with you every time he comes, ask him to say a poem or a song, and listen if you can make out any speech mispronunciations or nasality, and in that case refer back to the surgeon early. Otherwise, immunization and the routine pediatric surveillance is as per your normal children. And in the long-term follow-up, obviously, you have to tell the patient to keep following up till the end of growth. So these are the results that you can expect. Even with very wide clefts, you can get a reasonably good aesthetic result. So palatal fistula is one of the late complications of palatal surgery. And depending on its location, there's a classification. And the most common that we see is this junctional region because that is the area of greatest tension. So if there is a small fistula, then we just do a re-repair of the palate the same way that we did it earlier with the bipedical incisions, nasal layer closure, and mucosal layer closure. Some cases, if there is a big hole and there is breakdown of the soft palate also, then we use a buccal mucosal flap, as I showed you earlier. So for secondary corrections also it is used. This is another patient where buccal mucosal flap was used. So this one had a large anterior fistula also, but that is going to be dealt with later at the time of alveolar bone grafting. This is more important for his speech rehab. And you can see how well the buccal mucosal incision heals, flaps heal. Now, if you have a very large anterior fistula, then this is not going to be possible at the time of ABG because your ABG will fail. You will not have enough tissue for a watertight closure. So in that case, then you have to use another flap because the buccal flap will not reach there. So in that case, we use the tongue flap. So first you have to dissect the fistula, get a good nasal side closure, and then on the oral side, you will put the tongue flap. This tongue flap will be then later on divided at 2 weeks. So it's very important that when the patient comes for division, you have to have a good oriented anesthetist because they will have to intubate from the side of the flap. So this, you can see a healed, well-settled tongue flap. Another adult patient, same thing. And you can see you can cover almost the entire width of the palate with this thing. Another common problem that you can have in this 3 to 5 year age group is the speech problems, or termed as velopharyngeal incompetence. So the palatal area is termed the velopharyngeal port. So if the palate is weak or there is a hole in the palate, then that will obviously not close the port. So in that case, the air will escape and you get that typical nasality, which is termed as cleft palate speech. So this is a patient which shows a broken and scarred palate. Broken palate, there's a small hole here also. So the first step obviously is the intraoral examination. So if you have identified an anatomical defect, then at least you can start planning what kind of flaps you will need for the repair. The second step is you have to do a speech assessment by a trained speech therapist. And you should have a speech recording, because after the surgery, you will again compare the speech recording to see the improvement. And if you can have an objective assessment of the fistula, either using a nasoendoscopy, video fluoroscopy, or lateral palatogram, then you should do that also. So these are the options. You can re-repair if it is a missed submucous cleft palate, because that is a common thing. The palate is intact. It might not have been missed in childhood, and later patient is referred only for VPI. Then you can just do your normal cleft palate repair. And if there is shortened or scarred palate, then you can use a buccal mucosal flap. Now, in cases where you feel that just the gap is too wide, more than 1 centimeter, you can do a posterior pharyngeal wall augmentation. We usually use a costochondral graft, but you can use fat injections also. And this new technique has been developed by an Indian plastic surgeon called hybrid palatoplasty, where you combine a furloughs or a buccal mucosal flap along with a small pharyngeal flap. So the large pharyngeal flaps which cause obstructive sleep apnea are no longer used. So this is again a short scarred palate. There's no hole, no fistula, but it is a short scarred palate. So that is why the speech function is poor. So we have to lengthen the palate. This is the marking for the buccal mucosal flap, which will be used transposed nasally and used to lengthen the palate. Now for posterior pharyngeal augmentation, like I said, we use a costal cartilage graft. We use the stainless steel wire as a marker, because as you saw the earlier photos of the lateral palatogram, we'll do it again post-op and see whether we have inserted the cartilage at the proper level, at the velopharyngeal port closure level. So this is the repair of the muscle. It is known as intervelar veloplasty. And you can see post-op, we have got good lengthening. It is almost touching the back of the palate. Plus, there is this bulge over here, so the velopharyngeal port closure will be good. This is a submucous cleft palate. So in this case, you don't need any buccal mucosa because tissue is adequate. You can just do a intervelar veloplasty. That is repair of the muscle. So like I was saying, we can use this to compare. This is the gap. And this you can see the stainless steel wire is, so that will serve as a marker for you, whether you've inserted it at the right level. So the lateral palatogram is taken in various positions of speech. So the S sound is the most difficult for a cleft palate child, because that requires very good control of the velopharyngeal port. So if you get a good sound in children without escape of air, that means your palate surgery is a good surgery. So this is what you see on the nasopharyngeal, on the nasal endoscopy. That also is a real-time scopy. This is just some screenshots that we have taken. So this is the port closure. This is the posterior pharyngeal wall. This is the palate, and these are the lateral walls. So you can see pre-op there was this gap, and post-op now it's closing nice. And alveolar bone grafting is the other primary surgery that is done. So all cleft children, you have to counsel them to take good care of their teeth, because the future surgeries will very much depend on the condition of teeth. So we regularly refer to a pediatric dentist. Prevention of caries is very, very important. Then in the mixed dentition phase, starting from around 6-7 years, we refer to our orthodontist, who will align the teeth and the arches prior to doing the alveolar bone grafting. So you can see how this patient had a poorly aligned arch with inturning of the teeth. So different methods can be used for this. They have used brackets and niti wire to align the teeth. Sometimes the arch is very much constricted. Then they use this distractor called a Hyrax distractor to expand the arches. So once the gap has been properly prepared, then we can go ahead with the bone grafting. So you have to raise the upper GP sulcus. You have to, if there is any palatal gap, then you have to close the palatal side gap, and you identify the margins of the bony defect. Once that is identified, then you harvest a cancellous bone graft from the iliac crest. You pack this bony cleft with this cancellous bone graft, and you have to get good watertight mucosal closure for your graft to survive. So you can see there was this gap in the pre-opus of the orthopantomogram. The patient was prepared with the Hyrax distractor. The patient's alveolar bone grafting was done with the iliac crest bone graft, and post-operative you can see how the orthodontist has guided the eruption of the canine or lateral incisor into this cleft. So where there was a hole, now there is a tooth. So this is the protocol we follow. Lip and anterior palate 4 to 6 months, palate repair 9 to 12 months, ongoing dental and speech assessment. If any VPI or palatal fistula is there, we treat it in this period. At 7 to 9 years, we start doing the alveolar bone grafting. Sometimes if it's delayed, we can do it later on also. And the palatal fistulas, whatever age they present. So if you do the primary surgeries well, then your next follow-up surgeries are going to be easier. So a good lip repair with the anterior palate, your palatal repair will be easy. There'll be less chance of junctional breakdown. You've done a good lip and palate repair, then your alveolar bone grafting will be easier because there'll be good soft tissue. The condition of the soft tissue will be good. There won't be big holes. So every surgery you should give your best, and you should try to avoid these kind of secondary deformities at all costs. Okay. So, Sir, Dr. Mokal is going to talk about how to deal with those. So what our aim is to get a happy child, happy family.
Good afternoon, everyone. I'll be talking on the management of the secondary cleft deformities. Our aim is to provide the symmetry, continuity, and function. As Dr. Mahinoor has already described, that we want to have a good Cupid's bow, filter column, and good continuity of the orbicularis of calamus. The cleft deformities you have divided into extraoral soft tissue deformities like scars, contractures, lip and nose asymmetry. Intraoral soft tissue deformities involve the soft palate breakdown and VPI corrections. And the orofacial skeletal deformities, which consist of anterior palatal fistula, dentoalveolar fistulas, and maxillomandibular jaw occlusion, malocclusions. In unilateral cleft lip nose deformities, we find that there are scars, there might be a white roll mismatch, raised cupid's bow, vermilion, dry and wet mucosa mismatch, hypoplastic cleft lip segment, alar columnar tip, and dorsal nasal deformities. This gentleman operated case of cleft lip presenting with a notching of the upper lip. With you can see that there is a discontinuity in the white roll. The cupid's bow is elevated and peaked, and we call it the peaking of the cupid's bow. And we have marked the necessary points which are required to be continued. Create the defect. We have removed the scar. We have done a small Z plus T on the top to bring this white roll down and then connecting this white roll to white roll. We had a discontinuity of the muscle along the scar. We repaired the muscle and then we did a small Z-plasty on the top of the columella and a white roll, and we have rearranged all the red mucosa, dry mucosa, and the wet mucosa in that area to give that symmetrical alignment. You can see that there is a symmetrical alignment in this continuity of the white roll as well as the mucosa. And this is how the result. You can see that near normal without any blemishes is has got good continuity of the white roll and the muscle. Another patient with the continuity and the profile. Sometimes these patients they do have a less amount of hair into that area. So we can harvest the hair grafts from either from the beard or from the scalp. And we do hair transplant just next to the scar revision area, and this is the long-term result. This is the hair graft which is camouflaging the scar area. Then there is a consistent deformity of the cleft where there is a downward displacement of the alar cartilage, decreased columnar height on the affected side, and wide alar base. It is also associated with septal deformity. There is always a septal deviation, not only anterior-posterior, also vertical septal deviation. So in that scenario, we do an open tip rhinoplasty. We go by open approach. We identify the affected alar cartilage. Affected alar cartilage, and we release that cartilage from the lateral crus as a composite chondromucosal release. And then once we release that cartilage, it creates a small defect in that area, and we bring that cartilage to that normal level. And this is a defect which is created, which I will tell you how we cover that defect. You can see that this cartilage is restored back to its new position. Then for the septal deviation, we harvest the cartilage graft from the boomerang groove, and it helps in correcting the bony deviation. And this cartilage graft, we place it in front of the caudal border of the septum, and we place it in between the two crura, which gives support to the alar cartilage. It also gives a lengthening of the columella and the tip projection. You can see that these are the two affected cartilages. But once you give that solid columella strut, it supports both the alar cartilages and gives a good columella lengthening and the tip projection. Then another piece of a graft. This is the one graft we already used, the columella strut. Another piece we put it as an alar extension graft from the alar cartilage deep down into this area. So this is a graft which supports that extension. This discontinuity gets continued down, and it will rest into the piriform area to provide the alar symmetry. This is the additional graft which placed here, so that provides a good symmetry like a tripod. Most of the cleft patient, they do have a wide nostril base. We do a Y to V advancement, like a Y to V advancement to restore the alar symmetry. This is how it's a diagrammatic representation where you release the Y into V to get that alar symmetry. And then we suture, redrape the entire nasal skin, and we find that there is always an excess amount of alar skin here. So we take that marking here, and then we raise a flap, a laterally based skin flap. We call it the alar rim flap, and we line it inside the defect which is created after release of the lateral crus, so that this skin is lined inside and it provides this particular closure nicely without any raw area inside the nostril causing any contraction. So this is how is the equal symmetry which is achieved on table, and this is a good tip projection, LR based narrowing and symmetry. And this is a symmetry pre-op and post-op achieved on table. Sometimes I do a rhinoplasty in a patients where of a teenage requiring alveolar bone grafting. So we do simultaneously rhinoplasty, septal correction, and alveolar bone grafting together. So it's drastically changes. This is a septal correction. This is the layer which is repaired. Nasal layer, oral layer, a bone graft, and a suturing. And these are some of the results which are given during the time where the child is into the mixed dentition requiring a bone graft, and he is in the transition zone of childhood to adulthood. They are psychologically also disturbed because of their external deformity. So we take this opportunity to do both the lip nose revision and alveolar bone grafting at the same sitting. To provide these results, you can see how the symmetry and everything is achieved by just one procedure added along with your procedure of the alveolar bone grafting. You can see the projection. You can see how the cupid's bow is restored to its new position, how the nose is restored to its new position. And this is how it drastically impacts the psychology of the child, and they present it with a new joy of in their life that their nose has restored back to its position and treated all the deformities together. And this is a patient which is rehabilitated at the end, and the same patient treated with alveolar bone grafting, and now he's 30 years old. He's an IT engineer and he's doing extremely well. So these are the patients, they do well with only orthodontia, only alveolar bone grafting and cleft rehabilitation. And this particular article is published in Indian Journal of Plastic Surgery in 2009. And these are some of the adult patients which are treated with cleft nose rhinoplasty with all the good results of profile, a tip projection, and the symmetry which is achieved. So in case of a bilateral cleft lip deformity, we have a scar, then we have got a midline vermilion deficiency, we have a short columella, and there is a shortage of the upper lip. So I have divided the bilateral cleft deformities into three types. The type 1 is where you get adequate good soft tissue and adequate nasal framework to work on it. Type 2 where you get adequate upper lip soft tissue but inadequate nasal skeletal framework. So you have to import some skeletal framework. And type 3 is that you have an inadequate upper lip soft tissue and inadequate skeletal framework. You have to import both. To import the soft tissue, you have to import the skeletal framework. So this is a classic picture where you get an adequate upper lip soft tissue and adequate skeletal framework. You get good quality of the soft tissue. You can just have to revise it. So we required to have a good columella lengthening and a vessel tip correction. So this is one of the procedure which we have devised and accepted internationally. We use excess skin from the upper lip, the filtral column area, as a fork flap to lengthen the columella, and we create a good central cosmetic unit as an island prolabel flap based on the subcutaneous pedicle. This is islanded prolabel flap. So this is the islanded prolabel flap which is based on the subcutaneous pedicle, and those two fork flap are used for the columella lengthening. So these are the two fork flap. They use it for the columella lengthening. So this is the columella lengthening which is achieved, and these are the fork flap. And this is how we achieve the nostril closure, the lip closure with the good continuity and creation of the both cupid's bows. And this is the pre-op and the post-op on table. And this is front view, worm's eye view. And these are some of the patient's results. You can see how drastic change in her columella and the tip projection. How well is the projection of the tip and the lip. And the lateral view showing the restoration of the lip columella angle, the tip restoration and the upper lip restoration. And the good continuity of the upper lip, the scar, the very well settled scars and she got married after this operation. Another baby with the same procedure, columella lengthening and a lip revision. You can see the marked difference in his presentation. You can see the profile, how much good tip projection, good lip projection, and good restoration of the continuity. You can see that almost restored to near normal. Adult patient requiring the bilateral alveolar bone graftings and other procedures with the lip revision and the projection. So this particular article, again, it is accepted in our Indian Journal of Plastic Surgery in 2017 by me and Dr. Mahinoor. So in type 2, where you have got a good soft tissue, but you don't have a good skeletal framework, you can see that in a lateral view, there is the columella is short and the nasal tip has got no support at all. And there is a central element visual tip type of deformity. So we do a lip revision. We harvest the cartilage graft from the chest, costal cartilage graft. We use 2 grafts for the dorsal augmentation, 1 for the columella strut, and 2 for the LR extension. And this is how we restore his columellar height and the lip revision. And you can see that it is a marked change to normality with the good symmetrical nose, good projection and profile. You can see that the profile is restored very well. And this guy is a graduate from Cleveland University. You see the amount of confidence in this boy. We were so happy that we could restore it to its normal level. Type 3, where there is inadequate soft tissue, inadequate skeletal framework. You can see that there is no columella at all. There is no columella here. The soft tissue is not there. See, lip is almost not there in the midline. So you need to import that lip, need to restore the soft tissue and the skeletal framework. So what we do is that we did use a prolabial segment to restore, make her new columella, a rib graft for her dorsum and the columella support, a reconstruction of the nose by dorsal and columella support, and then a central tissue deficit. We have used a Abbey flap. We've taken a flap from the lower lip to upper lip. So this is a flap based on this labial artery, which is then turned up to restore a new flap. So the upper lip is new central cosmetic unit is reconstructed with a lower lip called as a lower lip to upper lip Abbey flap. And the skin closure is done with the Z-plasty for the good lengthening of this procedure so that the scar settles well. So this is first stage of the surgery where the nose has been corrected and the upper lip to lower lip is joined together by Abbey flap. And after 15 to 3 weeks, we have disconnected the Abbey flap once the blood supply is established. And you can see marked improvement in the result. You see that the lip is restored well, the continuity is restored well, the nose has good projection, and the lateral view showing a good restoration of the lip columella angle, the upper lip and the lower lip. Because his lower lip is more, so we use a tissue from the lower lip to reconstruct the upper lip. So this is a procedure called as a upper lip to lower lip called Abbey flap and a simultaneous rhinoplasty. Another patient with a similar deformity with the Abbey and around nose rhinoplasty with costochondral graft. Another bilateral with post Abbey and rhinoplasty. You can see the profile, restoration of the profile. Another patient with the same type of deformity. So you give them a good near normal restoration. And this article also secondary cleft nose deformity with simultaneous airway flap, which is again published in 2014 in Indian Journal of Plastic Surgery along with Dr. Manpreet. Some of the patients do present with the maxillary hyperplasia because this is one of the complications of the cleft palate surgeries. Nowadays, with extension alveolar palatoplasty, we don't get this type of deformity. But in the past, we used to take an incision and bang onto the lateral cleft area. And because of the scarring, the maxilla tends to get the hypoplastic and less developed. And patient presents with this type of deformity, where a classic deformity called as a class 3 malocclusion, where the upper teeth are not aligning with the lower teeth, with the lower jaw is much beyond the upper jaw. So in this scenario, she has got almost 12 to 13 millimeter of a discrepancy. And if you want to do a normal osteotomy, you cannot do osteotomy movement more than 6 millimeter of mm. So otherwise it will get relapse. So in order to get a good large movement, we come out with a technique called as a distraction osteogenesis, where we do osteotomy. And with after doing osteotomy, we put a red device. This is an external rigid device, which is then fixed to the rigid fixation onto the palate, onto the maxilla. And then gradually that maxilla is brought forward after rotating the screws, one turn in the morning, one turn in the evening. So 1 millimeter per day. And we gradually bring the maxilla forward. And as we gradually bring the maxilla forward, the surrounding bone as well as periosteum deposits a new bone. So this is a new bone is formed as you distract the jaw forward for the distraction osteogenesis. And then once the distraction is complete, you can see that the entire maxilla is brought forward and gone way beyond the limit to that of the lower jaw. And then after that, we keep this frame for at least 3 months so that whatever new bone is formed, it gets matured well. And then after 3 months, we remove that skeletal framework of a distraction frame. And this is how is the result. And this is how is the final result, where we did a rhinoplasty on this patient. And you can see that result pre-op, after distraction, after rhinoplasty. You can see the profile and the lateral. We can see the marked difference with this technology, that this patient which were maxilla which was way behind, brought forward, and with the nose rhinoplasty, you see that nose, lip, everything is brought to its new position. Sometimes in a mixed dentition, some patients they do have a velopharyngeal incompetence, and we don't want to bring the entire jaw forward, so it will compromise on their speech. So our orthodontic colleague, we will plan these cases for the anterior maxillary distraction. So this is anterior maxillary retrognathia, where that is divided into anterior maxilla and posterior maxilla. And the posterior occlusion appears to be good, but only there is anteriorly, there is marked canting. So in this scenario, we can break the anterior part of the maxilla. We do the osteotomy. The space is created by my orthodontic colleague at a premolar level. And then we can place the distraction apparatus onto the maxilla. So these are the indications where the tooth size arch discrepancy is there. That is the indication for the anterior maxillary distraction. So this is how is tooth size greater than the arch length. And this is a velopharyngeal incompetence, where you can bring the maxilla forward without changing the area of the velopharynx. These are the patients with the poor bone quality are not suitable for the regular rigid fixation. So we go ahead with the Hyrax type of internal maxillary distractor. So what we do is that we realign the arches, we create the space, and we do a CT scan to do the planning where the cut on the premaxilla, cut on into the piriform area, and we bring the premaxilla to its new position by anterior maxillary distraction. So this is how we created the space. You can see that the spaces are created to place your distraction apparatus and to place your osteotomy cut. This is how our orthodontic colleague will take the measurements to prepare the splint, and this is the distraction Hyrax screw band which is placed onto the jaw, and then we do a cut here. You can see that take an intraoral incision and take a cut into the piriform area and then cut in between the teeth at the premolar level, and then the apparatus is then activated by turning the screw intraorally. That is the osteotomy line, where you can see that once we turn the screw, we can see that there is a distraction occurs at level. So this is a screw where you have to turn one screw per day. You see that we train the parents how to turn the screw. This is how the screw is turned so that the anterior maxilla gets distracted forward and the new bone is formed at the level of the premolar. So in this scenario, 1/4, 1/4, 1/4 turn per day. And this is how you bring that entire maxilla forward. You can see that this the maxilla has come forward and it is maintained with the bow. So this is a post-op result where you can see that this much amount of distraction is achieved. And then once the maturation occurs, we can place in a good osseointegrated implant in this bony gap. And you can see the profiles where marked improvement into the jaw profile where with the distraction the upper jaw has come forward. So this is how we do a anterior maxillary distraction to correct the upper facial deformity. This can be done during the age of the childhood. Then this is an adult patient where there is severe overcrowding of the upper jaw, cleft deformity, class 3 malocclusion. So at first level, we have to align all the teeth. You can see that the teeth are so malaligned. Aligned it nicely with the bands, and then there are 11 millimeter of the gap, reverse overjet and a deep bite. So what he requires is the maxillary advancement, mandibular setback, and he has got this concave type of a face. So we have to have a high Lafort osteotomy to bring the entire maxilla forward to its new position. So this is a CT showing the deformity of that patient, and you require some amount of augmentation in this area. So in this case, what is the plan? The plan by our orthodontic colleague is that the maxillary advancement by 5 millimeter, the mandibular setback by 7 millimeter, and horizontal reduction of the chin by 4 millimeter. So with this, all documentation of the force dose transfer and mock surgery, he create two splits. One is intermediate split, that is we do a maxillary osteotomy, do the fixation with the intermediate split, then we remove the split, then we do a mandibular osteotomy with the final split. So this is the intraoral exposure, both lateral buttresses. This is the osteotomy which is marked, and then we fix the jaw into an intermediate split. Fix the jaw into the intermediate split, and then we fix it with the help of a plates and screws. Fixed with the help of a screw L plates and screws. Then we do an intraoral exposure. We remove the intermediate split. We have done the fixation of the maxilla. Then we expose the bilateral sagittal split. This is the exposure of the mandible, where we mark the osteotomy lines. And we do a sagittal split osteotomy. And we fix it with the help of a plate and screw. And that 7 millimeter of the bone piece And this is the horizontal genioplasty 4 millimeter measurements. And this is a reduction of the 4 millimeter of the genioplasty. And those 7 millimeter bone pieces were placed into the piriform area as the augmentation, both the sides. They are fixed with the help of a screw. These are the bones which are fixed with the help of a screw. Then this is very important stitch where when you do a maxillary osteotomy, you need to bring that maxilla forward. And the soft tissue also need to be reattached to its new position. So we do a alar cinch of the soft tissue to the bony points at the anterior nasal spine region. And this is how on table result. And this is how the result pre-op and the post-op. You can see the marked improvement in the profile. The pre-op and the post-op. You can see the jaw and the profile. And this patient is requiring a nose rhinoplasty. This is much severe form of a cleft deformity where the jaw is overgrown, the maxilla is way back, almost 17 millimeter of the overjet. The lip is scarred, there is a visual deformity, there is a columellar shortening. You can see that the deformity is very severe. And when we planned this case, we required 12 millimeter of a maxillary advancement and BSS setback of 8 millimeters and vertical reduction of genioplasty by 5 millimeter. But in this scenario, we cannot bring the maxilla forward by just one go. So we decided to divide this procedure into two parts. So we did a stereolithographic models and we have planned for the maxillary osteotomy, a high Laffotte maxillary osteotomy. And we have devised an internal distractor device where these are the foot plates which will fall onto the zygoma. These are the foot plates will go onto the maxilla. And then on table, outside the table, beforehand only, we have pre-bended these foot plates onto the model. So we know where exactly your foot plates are going to get placed all throughout the time of a distraction. And then this is the osteotomy line which is marked. And we get this model either ET or plasma sterilized on table. So then when we expose this osteotomy site, we first place this distractor apparatus onto this area and we pre-hole the foot plate areas so that we know where exactly your distraction apparatus is going to place. And then we do osteotomy, Laffotte 1 osteotomy, and then after the osteotomy is complete with the pterygomaxillary disjunction, we place our distraction apparatus and these pre-hold screws are placed and then the distraction is started after 4th day. So after that, after 12 millimeter of maxillary distraction after 12 days, we achieved this results. And after good consolidation, we waited for 6 months. After good consolidation of 12 millimeter of a maxillary advancement, you can see that the maxillary advance are good 12 millimeter. We have planned for, there is a X-ray showing a good new bone formation across the maxilla and good bone union. And we have planned, this is a photos of the occlusion where the maxillary teeth are good alignment with the lower jaw. And this is the second part of the surgery where we have to work on the lower jaw. So what we have planned is, the 8 millimeter of the mandibular setback and 4 millimeters of the genioplasty, both vertical reduction and horizontal reduction. So we exposed bilateral sagittal split osteotomy. We did a reduction genioplasty. You can see that this is a bony segment of the 4 millimeter, 5 millimeter is removed, and this chin has brought upward like a vertical reduction and backward by 5 millimeter. And this is the occlusion we achieved. So this is a profile. So once we did the skeletal framework is aligned, now we have to work onto the soft tissue. So what he had this deformity of the scar and the upper lip, and then we again used that technique of the subcutaneously pedicle idling flap, and then we did a columellar lengthening and lip revision, and this is how the result after lip revision. So you can see that how he progressed from the distraction to mandibular osteotomy and lip nose revision, and with good occlusion, the profile, the lateral profile, and this is 3 year post-op. You can see that the maxilla and mandible are still in normal position. The profile is maintained and the upper lip without any stigma of cleft lip nose deformity. And this is how we want to achieve a good results in this type of patients. These are the results on another patient, similar type of patient. And our final aim is to patient has to have a good smile. So this is a patient, so severe deformity. We did a Lafort osteotomy, brought the maxilla towards a normal occlusion, and then a dental rehabilitation by then a rhinoplasty and dental rehabilitation by our orthodontic colleagues and the prosthodontic colleagues. So the take-home message is that the proper assessment of the good skeletal and soft tissue deformities, use of buccal and tongue flaps for treating the palatal fistulas, restoration of the facial profile by good preoperative orthognathic planning by orthodontist, prosthodontist, exquisition of the good orthognathic osteotomies using piezo saw and advanced fixation techniques, planning of the better cosmetic unit restoration using island pro level flap, lower lip abbey flap, and a bilateral cleft lip, and regular follow-ups and touch-ups you may require like a hair graft or fat graft to do a minimal contour and hair deformities. Thank you very much. Do you have any questions or answers? Comments? We have a 15 minutes break. So any question, answers, anybody who is logged in? Somebody asked chat box 15. No? Okay. Okay. Where are the messages? There are no comments. There are no comments. Anybody, any questions? We are inviting. There are no questions in the chat box. You can unmute and ask if you have got any questions. Padipandi. No message. We will take a break for 5 minutes. You can have your cup of coffee, like we also having a cup of coffee. And then we'll continue the session after 5 minutes. Thank you.
Good afternoon once again. Good afternoon once again. So we'll be continuing with our session. So now I'll be talking on the Pierre-Robin sequence and its management. So from the historical point of view, it was first described by a French stomatologist in 1923 called Pierre Robin, and the name to that condition is from his name only. It was initially termed as mandibular hypertrophy. The incidence of Pierre-Robin sequence is 1 in 8,500 to 14,000 live births with slight female predominance, and occurs as isolated cases in 40% of the cases, and syndromic association is 60%. So basically the Pierre-Robin sequence, it is a triad. The clinical features which are included are micrognathia, glossoptosis, and airway obstruction, with associated symptoms being cleft palate. So why is it called a Pierre-Robin sequence and not a syndrome? So basically, sequence is a chain of developmental anomalies where one event leads to the next event. And in a syndrome, there is a primary insult and there are multiple manifestations of that insult. So in our case over here, it is called as the Pierre-Robin sequence because as we go through, you'll understand why is it called a sequence. So basically, during the development, the primary feature is micrognathia and retrognathia. The mandible fails to grow, and as we all know, the muscles of the tongue are attached to the mandible, and also the retroposition of the mandible. Because of the retroposition of the mandible, the tongue is also not able to move forward and downwards. So because of the retroposition of the tongue, the patient experiences airway obstruction. So basically, the genioglossus muscle is pre-shortened, and the ability to hold the base of the tongue forward is absent in these patients. So this leads to a ball wall type of inspiratory obstruction, which leads to the respiratory distress. Embryologically, the mandible develops from the first pharyngeal arch. It starts in the 4th week of gestation. So any insult occurring at this time hampers the normal mandibular growth and its positioning, leading to retrognathia and micrognathia. So as we discussed earlier, because of the retroposition of the mandible and the smaller mandible, the tongue is also displaced posteriorly, which is called as glossoptosis, the backward and downward displacement. The tongue obstructs the airway and interferes with the palatal shelf fusion. So the palatal shells initially are vertically oriented, and as the fetus grows, the tongue moves downwards, and the palatal shells, which are vertically oriented, gradually they become horizontal and fuse in the midline. So as the tongue bulk interferes with the movement of the palatal shelf, it leads to the formation of a cleft palate. So there are so the Pierre-Robin sequence is associated with certain syndromes, and it can occur as a non-syndromic isolated mandibular growth defect also. The syndromic associations, PRS, is seen in certain conditions like the Strickler syndrome, the velocardiofacial syndrome, and other genetic problems which include the COL9A1 gene, COL11A2 gene, and SOX9 gene. The clinical features which we notice for the obvious clinical findings is retrognathia and micrognathia. There is a U-shaped cleft palate. The tongue is normal in size, but the position of the tongue is abnormal. So these patients usually have airway problems. Airway obstruction is one of the features of the Pierre-Robin sequence. The airway obstruction is presented as cyanosis, apnea, and desaturation episodes. And because the patient is having airway obstruction, the child spends a lot of energy in overcoming this obstruction. So sometimes this also leads to feeding difficulties. which is manifested as poor weight gain, and chances of aspiration also increase. For diagnosing Pierre-Robin sequence, it is more of a clinical judgment, clinical recognition of the triad. Once the retrognathia and airway obstruction is noted, we need to get an assessment of the airway done. So endoscopic evaluation to confirm the airway obstruction. So normally in Pierre-Robin sequence, the airway obstruction is at the level of the base of the tongue. So endoscopic evaluation is needed to confirm if there is any other obstruction below the base of the tongue also. And sleep studies and feeding assessment of the child. So again, managing a patient with Pierre-Robin sequence, it is a multidisciplinary team which involves the plastic surgeon, the ENT surgeon, the pulmonologist, the anesthesia team, and later on, as the child has a cleft palate, also the speech therapist, the neonatologist and geneticist involvement if there is syndromic association. So for airway evaluation, sleep monitoring and oximetry, nasoendoscopy and bronchoscopy to locate the obstruction site and to assess the response of patient positioning, whether giving the lateral or the prone position is improving the airway. We need to understand that. Feeding assessment again. Sometimes, as we had discussed, these children sometimes have feeding problems also. These children, if the oral intake is not good and there is failure to thrive, then nasogastric tube may be necessary to supplement the nutrition of the child. The goals of managing a patient with Pierre-Robin sequences, the first and foremost is to maintain the airway. After that, once the airway is taken care of, we need to have adequate feeding, and we need to look after the growth of the child and correct the anatomical abnormalities and minimize the long-term morbidities. Again, same. First, we need to evaluate the airway, take care of the airway. Once the airway is under control, then we can attempt for a conservative management initially. If the conservative management fails, then we have surgical options, which we'll be discussing gradually. And the multidisciplinary team follow-up is very necessary in managing these children. So coming to the conservative management, once on the birth of the baby, Pierre-Robin sequence is established, when it's diagnosed, we need to understand that the child, first and foremost, again, the airway is important. So for the airway, the patient positioning, sometimes the prone or the lateral positioning helps to alleviate the airway obstruction in about 70% of the cases. In the supine position, the tongue falls back and the airway obstruction may be aggravated during sleep. So monitoring the O2 saturation continuously is necessary to look for spells of desaturation in these patients. One of the methods described for maintaining the airway in these children is the modified nasopharyngeal airway, where you can see the tip of the nasopharyngeal airway is going beyond the base of the tongue here, so that the obstruction which is there at the base of the tongue is overcome and the saturation of the child and the oxygen demand of the child can be met. Once the airway is secured, then we need to look into the feeding and nutritional support of the child. If the child is if the oral supplement or if the oral intake of the child is good, then we continue with the oral intake. And if there is some problem and there is failure to thrive, then the nasogastric feeding may be necessary. And these children have means the urinary sodium levels have been found to be low in these children. So the sodium supplementation also helps to improve the weight gain and the growth in these children. Even after conservative management, sometimes the patient do not respond. So in these cases, we need to look into the surgical options that are available. So basically, the surgical options that are available for these patients are like three. There is the tongue to lip adhesion, the mandibular distraction osteogenesis, and the tracheostomy. So we'll be going through these one by one. The tongue to lip adhesion indications is again failure of the conservative management. There is persistent airway obstruction even after positioning, isolated tongue base obstruction, and infants without erupted lower teeth. So in tongue to lip adhesion, basically this will overcome the mechanical nasopharyngeo obstruction. This is the historical purview how the tongue lip adhesion has developed or various techniques which have been used over the years. So there is one technique which has been devised by Dr. Nitin Mokal and Dr. Mahinoor Desai, which we routinely use in these cases for Pierre sequence. So if you can see in the diagram, so the lower part of the tongue and the lower lip, the mucosal and the muscles are hitched together so that the tongue is kept in the forward position and the obstruction at the base of the tongue is overcome. The advantages of tongue to lip adhesion is again the mechanical obstruction is relieved with immediate effect, and also the mandibular growth is not affected, and it is a simple and short procedure, and there is adequate space between the tongue and the lip mucosa to allow for the tooth eruption, and it can be easily divided at the time of the cleft palate repair. So here you can see this is a child with PRS where tongue to lip adhesion was done. The cleft palate was operated at around 1 year of age, and at the same setting, the tongue to lip adhesion was also released. So after the cleft palate repair and the tongue lip adhesion release, the tongue stitch is kept in situ just in case for as a preventive measure, and the nasopharyngeal airway is also placed. Once the child is awake and his airway is not obstructed, we can remove the nasopharyngeal airway and the tongue stitch. So we'll be going through one of the cases that were managed of Pierre sequence. It was a more severe form. So initially endotracheal intubation was not possible. The airway was maintained by using a laryngeal mask. A tongue to lip adhesion was done for this patient, but even after the procedure, the child was unable to maintain the oxygen saturation, and hence a tracheostomy was done in the same sitting. The parents were explained to manage the tracheostomy at home. At 8 months of age, the cleft palate was repaired. During the same time, a trial of decannulation of the tracheostomy was done, but the efforts failed, and hence it was decided to go ahead with a mandibular distraction at the age of 10 months. These are internal mandibular distractors. So basically, distraction is a process. Distraction osteogenesis is a process where we make a cut on the bone and gradually separate the two cut ends so that the rate of distraction, the rate of separation is such that new tissue is formed in between the gap, which gradually consolidates to form new bone. So here you can see the vertical osteotomy was done on the ramus of the mandible, and the internal distractors with the two foot plates were placed on either side of the cut. Again, this is the procedure on the other side. So once the bilateral osteotomy was completed and the distraction apparatus was placed, you can see the gap in between the two ends on either side. So gradually, as advancement of about 20 millimeters was achieved over 20 days. So it was the distractor was moved at 1 turn per day, which was 1 millimeter. Here in the X-rays, you can see the gap in the bone. In the second X-ray, you can clearly see there is a gap in the two ends. Approximately 20 millimeters of lengthening of the mandibular ramus was achieved. And after a consolidation period of 3 months, the patient, we could decannulate the patient, and so the removal of the tracheostomy and the removal of the distractor as well as the scar revision of the tracheostomy was planned. Tongue to lip adhesion was also removed in the same sitting. So at the time of the distractor removal, you can see the two ends of the distractors here. Initially, those were very close. So we had a bone deposition of about 20 millimeters in between the two ends. So this is how it started at 3 weeks. We had this severe case, and gradually over the time frame as the procedures were done, the child is now 12 years old. You can see in the lateral profile also the mandible has grown very nicely. The symmetry is also quite good. So again, this patient, we had done an internal distraction, but in internal distraction, only a limited amount of distraction can be achieved. So if we need more distraction, we have to go ahead with the external distractors. And again, internal distraction is only unidirectional, but it is better tolerance as all the scars and everything is inside, and but it needs a second surgery for removal. Also, external distractors, when the bone increase in the gain in the bone length is more, that time we use the external distractors. Multidirectional vectors can be planned with external distractors. And also sometimes simultaneous soft tissue distraction is also needed. So in those cases, external distraction is much better. So tracheostomy is specifically reserved only in very severe cases where all other conservative as well as surgical managements fail. In those cases only we go ahead and do a tracheostomy. It is sometimes required in cases with subglottic stenosis and tracheomalacia also. Thank you very much. Next, Dr. Mahinoor will be speaking on any questions, please?
उसने यहाँ किधर गया? Start screen sharing. I am already.
So slide. Slide. Yes, yes.
Audio.
Video is off.
Hi, good afternoon again. So we come to our last talk of the day, which is about rare craniofacial clefts. So unlike cleft lip and palate, where the incidence is 1 in 800 to 1 in 1,000, for rare clefts, the incidence is 1 in 100,000. So we'll just be talking about how to identify and classify them. And we'll see the various clinical presentations which are associated with the different types of cleft and how to evaluate these patients. I'll just give you a brief outline of what surgical planning and we do. And of course, this is also very much interdisciplinary treatment. So, like I said, rare means that it's 1 in 100,000 type dots. And the craniofacial clefts, the facial soft tissues, they correspond with the cleft in the underlying bony structures. It is not a random pattern. So Paul Tessier was a French plastic surgeon who first realized in 1976 that these clefts of the craniofacial soft tissue follow certain patterns, and he designed his classification on these radial lines which spread around the orbit, which is the central reference point. So what we start with in the midline is the 0 cleft going down and the 14 cleft going up, and so on. It'll go 1, 2, 3 will skirt the medial wall of the orbit, 4 will go to the central portion, 5th will go to the lateral wall of the orbit. And corresponding to these numbers 1, 2, 3, 4, 5, 6, you will have the cranial extension. So 0 will correspond to 14, 1 will correspond to 13, 2 will correspond to 12, so on and so forth. So, like I was saying, 0 to 7 are typically below in the lower half of the face, and 8 to 14 are in the cranial. And mostly the pairing occurs with the total adding up to 14. So 0 to 14 are the medial craniofacial clefts, and these kind of clefts are associated with very commonly with midline neurological structure deficiencies. And if in severe forms, like Dr. Prasanna explained in his embryological basis, you get something called proencephaly. And these kind of children will probably die within the first few weeks or months of life. So you can have a true aplasia where the structures are completely absent, or you can have a dysgraphia where there is normal tissue, but it is cleft like this. And sometimes you have tissue excess or duplications, like here you have 2 nostrils on one side. So some of the clinical features that you see with these kind of midline clefts is the bifid nose, the hypertelorism, and very commonly associated with different kinds of encephalocele or meningoencephalocele, and frontonasal dysplasia. So especially in these kind of clefts, you should do an MRI to rule out any brain involvement. And of course, as with any of these rare clefts, you have to do a stage surgery. So your priority in these patients will be the repair of the encephalocele or meningoencephalocele, and followed later on by soft tissue and bony correction as required. So again, this is some of the associations of the features of the various clefts. So 1, 2, 3 will be like your cleft lip, except it will be atypical in location. And 12, 13 will be the corresponding orbital and cranial clefts. So you can get a median coloboma of the eyelid. And the mandibular clefts are actually known as the number 30 cleft. Okay. if you get a midline mandibular cleft. I'll show you a photo of that. So this is when it's only a superior part, there is no lower part. So how do you decide what gets priority? So any exposure of the eye, any brain tissue protruding down into the oral cavity, so that will get priority. Next will be functional. If there is any issue with the eye, again function, with the nose, breathing, or with the airway, then that gets priority. And first, obviously, initial 6 to 12 months, we'll do soft tissue correction, and bony correction will be done then later as the skeletal system develops. So this is a clinical picture of a cleft 3, where there is hypoplasia, means there is absent nasal tissue. And this is another one, cleft 3, with her anterior staphyloma. So this is kind of an emergency because we have to deal with the eyelid issue first. Of course, she presented late, around 5-6 months of age. That's when we did it. And these kind of patients, we will do a CT scan for imaging, and then we plan the surgery. So these are other photos of the different clinical presentations that you can get in these kind of clefts. Again, we will do the soft tissue correction first for this, and then alveolus, like we do alveolar bone grafting later on at 9 to 11 years, we do that later. So macrostomia is what we commonly come across when there is a cleft 7. So this is very commonly associated with different syndromes, craniofacial microstomia and trichocolons being the common ones. In golden heart syndrome, you get additional colobomas of the eyelid. So macrostomia correction is what is required as a first stage in these patients. Now, coming to your imaging and planning, like I said, CT scan will delineate the bony features of the cleft, and MRI is reserved only for those where you want additional soft tissue or brain imaging. Later on, you can use virtual surgical planning tools for your bony reconstruction, and you can even construct the 3D models like Dr. Mokal showed of the maxilla, and you can use patient-specific implants for the bony reconstruction later on. Now, early intervention is required for functional issues like breathing, feeding, or vision. And you do stage procedures, the soft tissue first and bony next, and aesthetic refinements at completion of growth. You may require neurosurgery, ENT, opthal, or speech intervention. And final rehabilitation, sometimes the tissue deficit is so great that they will never look completely normal. Unlike a cleft lip and palate, where they look almost normal, these children might not achieve the same result. So this is just an outline. At 0 to 6 months, we do the soft tissue and functional repair. 6 to 18 months, we continue the soft tissue reconstruction. 6 to 10 years, we do the primary bony surgery. And after 16 years, the final like jaw movements or any other major maxillofacial surgery. So you as a pediatrician, if you are faced with this kind of child, first you assess the airway and breathing, because some of these children might have stridor because of choanal atresia. So in the front, the soft tissues might be open, but behind there may be bony atresia. Again, if there are any feeding issues, do not hesitate to put a oral nasogastric tube for the feeding. And of course, if you feel that there is exposure of the eye, then refer for opthal reference immediately. So this is just an overview of that. Now, as a surgeon, we describe the surgery by the regions. So we divide them into midline, then the orbital and maxillary, then the macrostomia, then the lateral cranial wall and mandible. So this is just because the surgical procedures differ according to the region involved. So we'll see some cases of midline clefts. So this is a true median cleft lip. Because there is complete absence of columella, there is some suspicious soft tissue also in the midline, which could be an ankyphalocyl or could just be an accumulation of fibrofatty tissue. So we have done whatever best we could do for her by joining the lip and the palatal, anterior palatal, whatever closure we could get, we've done that. This is a patient with cleft 1 and 13, just paramedian. This is the defect in the bone. So since the neurosurgeon felt that this bony gap did not require acute treatment as there was no ankyphalocyl through it, we just did a soft tissue reconstruction of the nose. If there was an ankyphalocyl, then obviously that would have been tackled first. This is another case of a Tessier 3 nasal cleft where we have used soft tissue rearrangement and to get a near normal appearing nostril. So these kind of minor soft tissue corrections can be done anytime after 6 to 12 months of age. This is another one similar cleft 3 with a excess of tissue, which again we have readjusted to get a good looking nostril. So sometimes you have very wide clefts and this thing requires this planned approach where you divide into the lip unit, the nose unit, the orbital unit, and this will help you plan your incisions for the surgery. So we have to advance the lateral tissues medially and we have to adjust as best we can and we have to restore the eye to its normal level, the lip to its normal level and the nose as much as possible also. Always keep in mind that the orbit, the eye, the cornea should have adequate coverage. So if there is any shortness of the lid margins or eye closure is not complete, then that should get priority. So this is like, you might be faced with this and think, oh my God, what should I do? But again, you go step by step and go for the functional problem first, the eye, the breathing, the feeding. And like I said, if the tissue deficit is great, you will not get a perfect aesthetic result, but at least you have ended up with a better result than what you started with. So we can build on this later on step by step. So at the acute surgery, at least you close the nasal passages, separated the nasal passages from the airway, got a lip seal so the patient can feed and breathe normally. So this is over a period of time. With growth, you will get more tissue, so you can plan like a forehead flap for the nostril reconstruction. So now this child, I showed you earlier, there was an anterior staphyloma, which is an emergency. You should involve your ophthalmic colleague so they can do something for the socket, put a spacer at that time, and later on they can give a ocular prosthesis. So you can see that later on it's not so bad. It looks like a normal eye, but that's an ocular prosthesis. This is another child with again a severe Tessier foot cleft with complete absence of the maxilla. And over a period of time, we have done the soft tissue correction. First, we did the external soft tissue correction. Then second stage, we repaired the palate. Then we have done a little bit of fat grafting later on. So slowly, it improves. So this is one more of that. This is the result. So near normal. Again, over a period of time, she will require more soft tissue and skeletal surgery. So this is again another case where there was absent nasolacrimal drainage as well as the displaced medial canthus. And you can see there is complete absence of the right side of nose, both soft tissue as well as the airway passage. So in this case, since she was breathing all right from the other side nostril, we just did a soft tissue uh, reconstruction of the medial canthal tendon. And if we can at this stage do a ophthal probing and re-establish drainage into the opposite nasal cavity, then you should do that. So always involve your ophthal colleagues. This is another patient, similar kind of thing, reconstruction of the medial canthus and nasolacrimal duct drainage. This again, the nose we will tackle at a later stage once she grows up, maybe use a forehead flap. Macrostomia, it is known as the transverse facial cleft, and a lot of times it is syndromic. This child has hemifacial microsomia. This patient also, if there are associated abnormalities of the ear and jaw, more likely to be a syndromic presentation. So again, macrostomia repair, like lip repair, there will be some external markings for adjustment of the external soft tissues. There will be muscle repair and then external repair. And sometimes you have these extra tags which will be excised. So pre-auricular tags also, which you come across commonly, are also a kind of rare craniofacial cleft, 6, 7, 8. And this is the closure, post-op result. This is another child with hemifacial microsomia with microtia and occlusal canth because this side of the mandible is not developed. So once she comes into the mixed dentition phase, she will go for orthodontia. Sometimes with orthodontic appliances, they can lengthen the mandible. Sometimes you can do a mandibular distraction. But at the end of skeletal maturity, all these patients will require formal orthognathic surgery. As you saw in Dr. Mokal's presentation about orthognathic surgery, they will also require that. And this child, her encephalocele was corrected in childhood. So she will be now planned for a hypertelorism correction where the walls of bony orbits are moved medially. And that will give us an additional soft tissue excess in the midline, which we can reconstruct with a bone graft or a costochondral graft. So this is the movement that you get in the hypertelorism correction, facial bipartition surgery, where the orbits as well as the alveolus and the maxilla are moved medially. This is a child who had Treacher Collins with severe obstructive sleep apnea syndrome. So that is why we did a mandibular distraction. And after that, his obstructive sleep apnea symptoms were relieved. So a multidisciplinary team is a must for patients like this. So you need the plastic surgeon, who is usually the team leader or coordinator. ENT surgeon might be necessary. Most cases where the clefts involve the eye 3, 4, 5, 6, an ophthalmologist is usually there along with you. Speech therapist if there are palatal issues and speech problems. And in the initial phase, you might require a nutritionist. So an in-house nutritionist in your institute is very useful in these cases. And later on in the mixed dentition phase, you require dentists and orthodontists to help plan your jaw surgeries. And I cannot emphasize this enough, these patients have severe psychosocial issues because unlike cleft lip and palate, we cannot restore them to normal or near normal in most cases, especially with the very severe clefts. So at some point, they will have to learn how to accept their deformity and to continue life and enjoy life and excel in life with that deformity. So this is just an overview. You can take snapshot if you like. Thank you for your participation in today's meeting.
Investing in real estate. One is considering the Indian sentiment and our
If there are
sentiment
any
for owning a
questions,
home,
you
one
can
is better
always email us at Narayana Help. We're happy. And Dr. Nitin Mokal will just give a concluding talk and conclude.
First of all, thank you very much for joining us for today's masterclass. Uh, 2, 3 points I would like to insist that we have to concentrate on prevention aspect also. We have to encourage all these college going students, all those young couples who are going to plan for marriage. We have to tell them to have a healthy lifestyle. The mother should take vitamin B complex with zinc, have a healthy lifestyle, and then plan your pregnancy. If your both parents are healthy mentally and physically, then your child will be normal. So all these deformities can be controlled and prevented. So that is one aspect. So spread this message. The prevention is more important than treating these babies. Second part is if coincidentally if the antenatal period the child gets diagnosed that patient having a cleft lip and palate. The cleft lip palate is a treatable deformity. So please don't advise them to terminate or even if they want to terminate, you can tell them that it is a treatable deformity and please don't terminate. And we have got lot of facilities available. If your finance status is not good, then we have got a Smile Train project going on at Narayana as well as Shishrisha Hospital where we can do cleft lip palate and other procedures free of cost. We have got good CSR department where all craniofacial cases can be treated under CSR projects. We have got Mukhyamantri Sahayata Nidhi, we have got Rashtriya Bal Suraksha Yojana, where the cost is not the factor. Our hospital has got the expertise. You refer the patient to the expert people. My talk on the secondary deformities, all these secondary deformities are not treated by me. The primary operations were not done by me. So ours is like a secondary tertiary center who are treating the secondary deformities. So your first surgery should be a good surgery so that we can avoid complications of the cleft lip and palate surgery. Thirdly, it is very important to have a good team. We have a good team where we have got orthodontists, we have got the speech pathologist, we have got the child psychiatrist. So the team effort will not only give the parents to the patient a proper guidance, a regular follow-up which is mandatory that we can do the surgeries, whatever necessary things required at that particular time. So every year follow is very, very mandatory so that we can diagnose on whether the patient has got a hearing difficulty, speech difficulty, they are doing a arch collapse or dental occlusion collapse so that our orthodontic colleague can take care. And then after all the surgeries are over, the aesthetic come into the picture where we can do the good orthodontic surgery to bring all the skeleton to a normal level. We can repair the nose, bring the nose to the normal level. We can revise the scar. We can do camouflage procedures like fat graft or hair transplant, camouflage their scars. And lastly, the dental rehabilitation where you can provide them a good smile with a good dental rehabilitation. So all comprehensive cleft management is possible with our team. So please do consider all these points in mind and encourage in prevention and sending the patient to a proper hands for this type of treatment. Irrespective of patient whether is a poor or rich, we can treat them at any cost. Thank you very much for joining. If you have got any questions, you can write to us. You can get our telephone numbers from Narayana if anything required. We have got OPDs at Narayana. We do a lot of craniofacial at Narayana. All the secondary procedures can be done. Thank you very much for joining us.
Thank you, sir. Thank you.
Conference call regular.
आले प्रोफेशनल टच मध्ये
नाही मी बघितलं सर नाही
नाही.
चला.